Tarek, welcome in OSNT, and please share screen and start. Thank you so much.
Thank you very much, my dear friend, Dr. Fadi. Actually, it is my pleasure to be here. I want also to take this chance to thank Professor Issa Salmi, and definitely my dear friend, Dr. Fadi, who I'm quite sure that he is organizing a lot of very important and very useful scientific content for the Omanian society. And actually, it's my pleasure to be among the audience. I just wanted to make sure that my screen visible now? For
visible, but not full screen, I believe. Not full screen. Yeah.
Okay. So I will make it. I will make it full screen. Then I will
yes,
have a
please.
start. Okay, thank you. Okay, so so today I'm going to talk about this actually, as Dr. Fadi explained. Acute kidney injury is a very hot topic, and definitely the early detection of acute kidney injury. This is the unaccomplished mission, the unaccomplished task that it's still far from achievement. So today I'll be trying to touch over these 30 to 40 minutes over what are the most important concepts in the early detection and management of acute kidney injury. So to start with, in terms of competing interests, I have nothing to disclose in relation to this meeting. And definitely we will describe with the very basic what's acute kidney injury. So acute kidney injury, as compared to chronic kidney disease, describes a sudden or abrupt dysfunction of the kidney function that's determined based on the increased serum creatinine levels, a marker of kidney excretory function, and reduced urine output, oliguria, a quantitative marker of the urine production, and is limited to duration of 7 days. And as soon as we read this definition, we will realize where the dilemma comes from. So the definition itself states that we depend only on, so far, on two of the very important conventional and the classic markers for the acute kidney injury, which are the serum creatinine and oliguria, which is reduced urine output. And definitely, as life changes, as the world is evolving, everything, science is evolving every day, we have to move on. And why AKI in specific is gaining this too much attention? Because it's a very common condition in the hospitals. It occurs in about 5 to 7.5% of the hospitalized patients. But also we will notice that it constitutes percent of the critically ill patients. So it's a huge chunk of the healthcare system. It's a huge burden to both the healthcare system and mortality, meanwhile. And when we come to the definitions, just a reminder that we have several definitions. Definitely acute kidney injury is different from acute kidney disease, and is different from the chronic kidney disease. And essentially the main difference is where the time barriers come. When we say that this is an abrupt change in the kidney function within 7 days or less, that we can say that this is acute kidney injury. If that would extend to up to 3 months, and this would what we call the acute kidney disease, okay, and then we would have noticed at that stage that there is elevated marker of kidney damage in the form of albuminuria, hematuria, or pyuria. If it continued to progress beyond these 3 months, then we are talking about the chronic kidney disease, and definitely we will notice much more damage to the kidney in the form of albuminuria as a marker. So that was the acute kidney injury so far, that acute kidney injury definition that was widely accepted based on the 2012 KDIGO criteria, which I'm quite confident that all the audience are familiar with. But what is new? There is a new proposed definition for AKI that hasn't come yet to be enacted, but we will be noticing maybe in the next few years that we'll notice a change in the acute kidney injury definition, that we can see that there is a stage 1, S1A, 1B, and these will depend actually on this column to the right. So it depends on the diagnostic criteria, the biomarkers. So biomarkers are no more a fancy thing that we are talking about. Okay, I'm going to do this biomarker for research purpose. I'm going to impress people because I'm going to spell big names about the biomarkers and so on. No, it is now being embedded in the clinical practice actually. So it's no more a fancy, it's no more what we call it the Jaguar of the laboratory tests. Okay. Now, why early detection in AKI? Because we have to know that there are definitely gaps in the acute kidney injury care, and the management is often suboptimal. This has been acknowledged and has been appreciated in many audits, many reports, and here definitely the most famous of them, the 2009 LC Board report in the UK that found that almost 50% of patients of AKI were managed poorly, and the 43% of AKI cases were recognized late or not recognized at all. And that's where it has prompted that there should be change in the practice, a change in the management, that the things can't stay like as it were, and they started to develop the electronic alerts that I'm going to talk about in a few minutes, and then they embedded these electronic alerts into what we call the care bundles to try to optimize and improve the care of acute kidney injury patients. However, did we find that definitely this has led, did this satisfy the eagerness to bridge this gap and find the optimization? The answer is simply no, because if we will look at this presentation at the end, we'll find that there is no simple answer to bridging the gap of the early detection of acute kidney injury. There's never been a very straightforward answer that you can throw on the table and say, okay, yes, I've just found it. So when large enough sample size were considered, electronic alerts have measurable effect on the duration of hospitalization and on survivals. That's on a very wide scale. And it's a very interesting graph if we look at this here, that we can see that the most important, the reason why I put this graph is we have to understand that for healthy people, the kidney lifespan will survive the lifespan of the person. Unless there is a drop, which is an acute kidney injury, okay, that will lead to deviation from the normal graph. And acute kidney injury is not always reversible, so it can, and multiple episodes of acute kidney injury, cumulative episodes, will lead to the damage. The damage will still be there, and then that will lead to the shift of that curve or trend to a lower limits. That will depend on many factors actually, not simply one factor, and many of them are related now, evolving genetics and epigenetic factors. But we will have noticed that it depends on the endowment with the nephrons. How many nephrons have everybody has got in his kidneys? And when we look at this, actually, yes, when we have acute kidney injury, as we can see here, it's a healthy nephron, okay, but are we getting at the end of the recovery phase, are we getting this nephron back? So the answer again is not very straightforward, because it will all depend on these cells that are called the tubular progenitor cells. These cells have the capability of regenerating the tubular cells. So it's not always possible that these tubular cells are going to regenerate to the extent that they function exactly the same as they used to be before. And there is definitely the severity of the hit of the acute kidney injury from mild, moderate, and severe. We may end up with a very much distorted nephron that's no more functioning, and definitely that will lead to nephron hypertrophy and remnant single nephron GFR, and increased risk of chronic kidney disease and CVD, possibly the kidney cancer. So that's really worth it. It's really worth that we try to, if we say that this is a preventable disease, we want to prevent this from happening, that we end up with such distorted nephrons and such burden of morbidity and mortality at the end. Now, when we are talking about what are the concepts of early detection of acute kidney injury? Now there are four main concepts if we are talking about the concepts, and I have put them here overlapping or intercepting at certain points just to emphasize the fact that none of them is perfectly functioning. And to be able to obtain the results, the best results that will predict the patients with a narrow margin of error, narrow margin of false alerts, we have to combine some of these. So we have the early biomarkers, we have the electronic alerts, we have the optical biosensors, and we have the machine learning or the artificial intelligence. These are the main four concepts now that are operating or are being under research. However, they have found their way into the clinical practice for early detection and hopefully reducing the burden of acute kidney injury. Now I have put a star here on electronic alerts because this has been the usual or the standard of care in the UK. So if we are talking about what is the most common UK practice now, they are embedding the electronic alerts, which I'm going to explain more about, are currently embedded in almost all of the healthcare systems in the UK. And this is essentially an algorithm. So this algorithm is embedded in the lab system, where this algorithm is able to identify the serum creatinine, and then it will start to compare it to a previous value and to work out its way towards whether that's fulfilling 50% rise within the time interval of 7 days, or otherwise 26 micromole rise, or if we are going to talk about the milligram per deciliter, is it 0.3 milligram per deciliter rise within 48 hours or not? And based on that case, it will create an alert. That alert will go to the clinician, and based on that alert, it will give a specific, what we call the care bundle. So it will give a very specific advice on what you are going to do next. Definitely, understandably, the management of AKI is tailored according to the stage. So some of AKI stage 1 patients who are secondary to medications or dehydration can be managed in the community. Otherwise, the more severe AKI, like AKI stage 3, will require admission to the hospital. So it's tailored management, and it's tailored according to the stage of acute kidney injury. And definitely, it's also a set type of measures that it has to make sure that there is standardized care across all the healthcare systems. Now we are going to talk about the first domain or the first concepts of biomarkers for the early detection of acute kidney injury. And there is an unresolved need for the early detection of AKI before its progression, as we have explained before. And so a lot of biomarkers have been identified, and they can predict the occurrence of AKI. The problem with these are always the limitations of their use that I'm going to explain in one table in a minute. But interestingly, one of the medical centers in the United States developed an alert system to manage the ICU patients who are exposed to nephrotoxic medication. And it combined, actually, what had happened here is that it combined more than one, the kidney injury molecule, the NGAL, TIMP. So it's more than one biomarker. It hasn't to be one-man show that we depend only on a single biomarker. It's definitely the only one that has been FDA approved of them is the kidney injury molecule, the KIM. But there are other bedside kits to test them more than one biomarker. So it can be used for early identification of patients at high risk of developing AKI, thus allowing for timely and proper management. So if we take examples, there are so many biomarkers in the kidney, but we can specifically say that kidney injury molecule has been shown to be useful in certain things like the cisplatin and amphotericin related AKI. Now, cisplatin induced AKI, which is a cancer chemotherapeutic, has been widely studied because the pathophysiology and mechanism is quite distinct at the moment. And a lot of biomarkers have been identified as a result of the damage that the cisplatin can cause. Furthermore, the NGAL levels have been shown to reflect cisplatin and amphotericin induced AKI. How long? 0.5 to 3 days before. So it's worthy it, definitely. If we're talking about cost benefits, it's worthy it that we are able to identify this acute kidney injury or predict it a few days before it's happening. So considering different biomarkers together may have clinical advantage. So kidney injury molecules and gels have been shown to be significantly elevated again in vancomycin-associated AKI and to increase earlier than the serum creatinine. So we have here the advantage of being ahead of time if we want to, for example, avoid contrast-induced nephropathy in these patients, optimize their hemodynamics, stop the ACE inhibitors, and so on. A lot of interventions can be done if we are able to say, yes, these patients have a certain biomarker that's raised, they had the vancomycin, and they are at risk of developing the vancomycin-associated AKI. When we talk about the biomarkers, because there are so many biomarkers, but mainly all of them will fit into this classification. So some of them are actual stress biomarkers, some of them are damage markers, and some of them are functional markers. Some of them can be detected in the urine, and some of them are detected in the plasma. And I'm quite sure that the audience have been are familiar with some of these names. So hepcidin and kidney injury molecule and liver type fatty acid binding protein. These are cystatin C, definitely. So these are some of the very famous biomarkers that have been used, but they all fall within this category. And when we look at this table, that we would realize that no biomarker is perfect, and none of them is actually complete and 100% reliable. And the reason for that, that the limitation that it can be raised in a number of certain other conditions here. So it's not 100% specific to the acute kidney injury, and here comes the dilemma. Okay, so if we take, for example, the kidney injury molecule, it can increase time of increase after injury 12 to 24 hours after injury. Somebody will think that that may be too late. No, actually, if we compare it to the rise in serum creatinine or oliguria, that's pretty much early. But also, we will notice that kidney injury molecule can be elevated in a number of certain number of other conditions, like elevated in proteinuria, inflammatory disease, and patients undergoing cardiac surgery, and so on. And so is the case for all the other biomarkers. So I like looking at this diagram and sharing it because this is the concept, as simple as it is, but this is the concept. This is not a brand new flow chart or diagram. That's dated since 2012, and that's one of what the KDIGO has suggested for the management of AKI. But what is most interesting and has led to all this revolution is this, that we actually, the most precious group here are not AKI stage 1, 2, or 3, but the most precious group are the people who are at high risk of acute kidney injury. We need to target this cohort of patients so that we avoid them undergoing this unnecessary damage. And definitely the KDIGO recommends that certain measures are applied when the risk is deemed to be high, even before the development of AKI stage 1. So we don't have to wait for the creatinine to rise to stop the ACE inhibitor, optimize the hemodynamics, or to refill the patients, reverse the dehydration. There should be, ideally, in the ideal world, there should be certain indicators to indicate that those people are high risk and going to have AKI within next maybe 48 hours, and then we start addressing this problem. So that was the how the concept is developing, how the concept is evolving. And this is interesting, going back to that diagram that I put at the start, that it's intercepting. Yes, people started to realize that it's only not one answer, but we need to combine more than one domain or concept to be able to get more precision, more accuracy. And yes, people are getting results. So here, this study was looking at the renal recovery after implementation of the electronic alerts and the biomarker guided kidney protection strategy. What they have done is that they have screened the patients who are undergoing abdominal or vascular surgery, and then they got an alarm. Once they got an alarm, they have done, this is an electronic alert, then they have done this biomarker. If they have done the biomarker, if that's above 0.3, that is moderate risk. So now they combine two concepts. If it's moderate risk, then they started to apply the certain protective measures here, which was all based on previous interventions. So we can say here that if patients are low risk, moderate risk, or high risk, definitely we might increase the frequency of observation of iron of the urine output, and apply more measures like stopping the NSAID and stop the ACE inhibitors and so on, aiming at the end that we get it timely. Okay. So what was the result was quite interesting really, because here when they have implemented this protocol, they found that the renal recovery of the kidney function less than 7 days was about 78%, which was coincided to an odds ratio of 0.36, and that was significant. 95% confidence interval was 0.14 to 0.8, so that it didn't cross over the 0 point, and so it was significant. And they found also that there was the AKI, definitely subsequently patients who had recovered AKI, that was linked to mortality. But this is not secret and not a surprise, because we know that AKI is linked to mortality, and when the AKI incidence, renal recovery improves, the AKI, the mortality will subsequently fall. So that was interesting. And I'm going to talk, so we have talked about two concepts, and now I'm going to talk about the third concept of early detection, which is the use of machine learning and artificial intelligence in the early prediction. So what is meant by machine learning? Because now the world is heading very persistently to the use of artificial intelligence. Is it perfect? Again. So the concept of machine learning is to use mathematical models to make decisions. So it's all about decision trees, okay? And to make predictions based on the data set. Machine learning differs from standard regression models. So we used to, and the statistics use the logistic regression, Cox hazard perception models, and so on, to find what are the confounding factors and what are the contributing factors and what is the ratio relative to each other. Now machine learning is much more advanced than this, because it can take a high volume of data that can be used as input, and the computational effort required for the analysis. Okay. So if we look at what machine learning looks like, so we collect the data, so we collect the patient data and feed it into the machine. And when we feed it into the machine, we are aiming to imitate the human brain, to learn the features. And then we run the validation data. And this is a very important step actually, because most of the models so far have not been externally validated, and so they are not applicable with a good confidence. And then we start to get the results. So we will say that if this patient blah 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 is going to get AKI stage 1, then there are certain set measures that we need to do, and that's all about the machine learning. So what did they found about the machine learning? So this is one of the models of machine learning, because it has got so many models and so many softwares and so on. But RRN, which is stands for, I always forget, it stands for the neutral neuron and that is mimics the human brain exactly. They try to reproduce the way of thinking of the human brain in that model. So what they have done in this study is that they have tried to see whether the receiver operating curve with this model of machine learning will be better than human prediction or not. So what they have done is that they have selected certain patients. These are the electronic health records. They fed the health records into the system and they trained the machine to be able, so they trained the machine to be able to predict that model. And then they have started applying this learned machine, that machine that has learned from these external health record data, which are retrospective data, and apply it for similar patients with similar conditions, and to see whether the prediction would be much better than the human or the physicians or not. And actually what we get is that, yes, so here in this model, they found that the RNN, the area under the curve was 0.9%. And the precision on call was 0.91%. So in terms of definitely in terms of the specificity, 1 minus specificity, the RNN model was superior, and definitely also in terms of sensitivity. So machine learning may be working in a sense, but definitely it needs more development, as I'm going to explain. This was another study done in the University College of London, and there was some collaborators from the US as well for the continuous prediction using this machine learning. So in their model, they found that 55.8% of the inpatient AKI event of any severity were predicted early within a window of up to 48 hours in advance. So that's quite a long time, with a ratio of 2 false alert prediction for every true positive alert. And sensitivity was particularly high in patients who went on to develop lasting complications. So this model provided early prediction correctly in 84.3%, which is amazing, where administration of in-hospital or outpatient dialysis was required within 30 days of onset of AKI. So artificial intelligence started to work in some way. Okay, so what's the problem then? So the problem of the machine learning, that nothing is perfect and no single model is perfect, because when they have done the systematic review about, you can see that so many studies and so many models have been looking into whether machine learning can get it right. So what they have found that are certain limitations, and that some of these limitations, as we can see here, is that related to the validation. So only one model of them had external validation, which doesn't give much confidence and trust when we try to reproduce these models in the healthcare systems. And definitely the high risk of bias of most of the study, and the concern over the applicability. So these were some of the and the conclusion was that the deep learning models are emerging, and they are leveraging the temporal data, text, and definitely they need more external validation, and need to improve interpretability and shared data and code. So we still have some way to go around. Now the fourth and last model, but not the least interesting, are the optical probe imaging and biosensors. And these are simply, again, that's what the future may look like in this diagram, that at some point we will be able to get for example, biomarker like an NGAL, get the result to the machine. The machine here is a very smart machine with artificial intelligence programming. We will be able at some point to use a probe which uses near infrared technology, or use the photoacoustic technology, which I'm going to explain now in a minute, to see below the skin, to see the kidneys, and to give us how much of these biomarkers are there, which is happening, which is it's an evolution. This has been impossible a few years ago, but now it's possible. So we'll get an imaging for these biomarkers, reactive oxygen species, and then we get them all into the machine. The machine will tell us at some point, yes, this patient will develop AKI most probably with a 90% confidence within the next 2 days, and we have to do certain set measures to avoid that from happening. So that's what the future looks like. It combines more than one concept, and they're getting it eventually into the machine learning, and they get a decision tree based on that. So what is the idea of the biosensors? That there are certainly disadvantages for the conventional images. We all know that contrast is not 100% safe, although I know that some people will agree or disagree with that, and some people will say contrast-induced nephropathy is just a myth. Some people will say no, we have seen a lot of cases of contrast-induced nephropathy. Whatever the view here, we will agree that the conventional images like the ultrasound and CT and the other images are limited, and we need to develop much more images to increase our understanding. So we are looking at here again combining two concepts, which are the machine learning and the biosensors, electric probes to detect the biomarkers. So in the recent years, there has been early diagnosis of AKI has made great progress with the advancement of the information technology, nanotechnology, and biosensors. And meanwhile, new functions of artificial intelligence have been unveiled. Branch of the artificial intelligence can effectively predict AKI by building the predictive model based on analyzing the large data. So definitely we get the biomarkers. Now we are aiming in this model to combine the biomarkers, the NGAL, the kidney injury molecule, the reactive oxygen nitrogen species, and get them into the machine. And we know that the concentration of these biomarkers increase before the onset of renal or organic or functional disease. So they are more sensitive, and we have agreed at this from the start, than the urine output. We don't have to wait that the urine output decline till we say that this patient has got acute kidney injury, because we can do it much earlier than this. However, the two methods that are commonly used now, which are the ELISA and the BCR for detection of these new biomarkers, look a little bit old-fashioned. So on the basis of that, the concept of biosensors arise, and that include that there are certain optical probes or electrochemical probes that can, with certain technology, reach where the light doesn't reach, and can show us the concentration of these biomarkers in the kidney in vivo. And one of these technologies are the near-infrared imaging, and this can overcome the penetrability limitation of the deep tissue imaging, because the near-infrared light have much lower absorption and scattering than the visible light in human tissues. That's another modality, which is the photoacoustic effect, as a mixed mode imaging method based in the photoacoustic effect. So that's combination of both the sound, like the ultrasound waves, and the photo emission. And this has the highest penetrability of all the known so far modalities. So let's have a look at what it looks like. So let's assume that we are going ahead with time. So that's where there is early damage to the kidney, reaching that there has been established damage to the kidney. And essentially these biosensors, now these are the triggers of acute kidney injury, whatever they are, sepsis, nephrotoxic, whatever they are, they have led to the release of these very injurious substrates, and that will do the damage to the kidney. Now, the main idea of the biosensors is that we are able to see these we are able to penetrate to the kidney of this mouse without sacrificing or severing the mouse to see it under the microscope, or without taking a urine sample or blood sample from him. And that has been a challenge. That has been sort of thing that is very difficult to achieve. But with these technologies, it's almost there. So we can see now that they started producing certain images, and we can see here these are the kidneys. And actually, with these models, we can say yes, that there is certain there are certain amount of these biomarkers. That was, for example, for cisplatin drug-induced AKI, and we can say yes, cisplatin has started to do bad effect to the kidney when it fluorescence with red, and that's definitely because even the urine output or the creatinine start to change. So we can imagine that combining this technology with the machine learning or any of the other technologies will be quite useful. And to that extent, I think I have finished. I'm almost done with the early detection. I'm going to touch over sepsis AKI management, sepsis-associated AKI management, just in a few slides, and then I will conclude. So in sepsis-associated acute kidney injury, there has been a consensus report which was published 2023, and this is the most. It's very worth reading it. Essentially, this is some statements come out of this consensus report that sepsis account for about 45 to 70%. So sepsis-associated AKI is really important cause of AKI, and it's frequently encountered the AKI and contributes to worse prognosis. AKI is diagnosed within 48 hours of diagnosis of sepsis, be defined as early sepsis associated, where AKI occurring between 48 and 7 days can be classified as sepsis associated. So that is a dilemma about the definition, whether it's sepsis induced or sepsis associated AKI. But the clinically relevant points which are very important, that what are the goals of fluid management in sepsis associated AKI, that it's very important to understand the central venous pressure, the significance of central venous pressure as a marker of congestion or sepsis associated AKI is uncertain, so that the CVP correlates only moderately with the overall volume status, so we don't have to insist to insert central line in any patients with sepsis and AKI to measure the central venous pressure. But the assessment of volume responsiveness should include the clinical perfusion markers like the lactate, which can be obtained easily with the VBG, and the advanced hemodynamic monitoring, whether it's invasive using ultrasound, whether it's invasive or non-invasive. And definitely in this consensus, it was still suggested to use balanced solutions and normal saline. However, we will see a trend towards using more balanced solutions rather than the normal saline being more physiological, and this has been pronounced in the Surviving Sepsis 6 campaign, which is the constitution for sepsis management all over the world. So the Surviving Sepsis 6 would prefer using the balanced solutions over normal saline. And definitely the albumin and bicarbonate may be of benefit in sepsis associated, but there is a very clear recommendation against the use of starch, gelatin, and dextran, and this is a strong evidence. So Surviving Sepsis 6 campaign have updated the recommendation in 2021. It's also very worth reading that, and the recommendations has changed so that we need to give the patients 30 ml per kg of IV crystalloid within the first 3 hours. So whenever sepsis is suspected, whether it is septic shock or sepsis-induced hypoperfusion, we need to give 30 milliliter per kg within the first 3 hours. And they suggested using either balanced crystalloid or saline. That was the old recommendation in 2016. This has been changed to a frank recommendation to use balanced crystalloid instead of normal saline. So that's the Surviving Sepsis 6 campaign, which is looks at overall sepsis management. And definitely there are also characteristics for there is a role for the use of extracorporeal blood purification therapy, the chronic renal replacement therapy and HDF and so on. But still, the ideal study has found that although early kidney replacement therapy initiation for sepsis-associated AKI has been used for fluid and solid control and to prevent multi-organ dysfunction, there has been no clear benefit has been demonstrated for earlier initiation. So I think a few take-home messages here that we can take, that there are definitely various concepts for the management, for the early detection of acute kidney injury. One concept might not be perfect, but combining more than one concept can definitely yield better results. And there is still definitely much room for optimizing care. And thank you very much for attendance, attention, and I'll be happy to answer any questions or comments. Thank you very much.